Yes, and welcome. So welcome to today's session. Today we'll be covering the development of the exoskeleton. Of course, you know my name. Yeah, that's my short initials there. And today, what is the scope of today's discussion or the objectives of the session today? We are going to, first of all, look at the components of the exoskeleton. We're also going to touch a bit on some of the components of the appendicular skeleton. Then we check on the development of the skull, the development of the vertebral column. Then also we are going to check on the development of the clavicle and the development of the sternum. So those will be the objectives for the session. And we hope by the end of the 40 minutes that we have, we'll be able to have accomplished that. Then for the first thing that we're going to check are really the components of the exoskeleton. So for the exoskeleton, the bones are found on the axis, the longitudinal axis of the body. So we start with the skull. So the bones, the components of the skull. So we talk about the various bones, both paired and unpaired bones, starting with the frontal bone, the parietal bones, the temporal bones, the sphenoid bones, the ethmoid, go to the mandible, the maxilla, all those bones of the skull. Then now we go to the vertebral column with the various vertebra, starting with the cervical vertebra. Then you go to the thoracic vertebra, the lumbar vertebra, and then the sacrum itself. And then not forget about the ribs and the sternum. So those bones now will form the exoskeleton, and those are the ones that we're going to discuss today. Of course, in addition to that, we're going to discuss the clavicle, the development of the clavicle, though the clavicle is not considered as a bone of the exoskeleton, it's an appendicular skeleton. It forms some part of the appendicular skeleton. So when talk about appendicular skeleton, it actually comes from the word appendages. As you know, the limbs come from the appendages, the limb appendages. So you realize that now the humerus, the ulna, the radius, all those bones, the humerus and even the femur, the tibia and fibula, we covered them well when we were talking about the development of the limbs. So maybe for your information, you can go and review that video on development of the limbs well. It's already there, so you can go and recheck on it. But today what you're going to cover, we're going to cover exoskeleton, given that the fact that we covered the development of the limbs, especially the bones. We remember the stylopod, the zygopod, and the autopod that we talked about in the development of the limbs. Yeah, so maybe to give us a brief overview of what you're expected to cover today. So I'll take us back to the three germ layers that we have. So remember the three germ layers. So for the three germ layers, we usually have the ectoderm, the mesoderm, and then the endoderm. So the ectoderm divides into two to give you the neuroectoderms. Remember, the neuroectoderms give you the neurotube and the neurocrest cells. And then the remaining ectoderm becomes surface ectoderm, which now becomes the skin and its appendages. So remember, the appendages now are the mammary glands, talk about the hair, the sweat glands, all those structures. Then for the mesoderm now, it divides into three. Where you have the paraxial mesoderm, the intermediate mesoderm, and the lateral plate mesoderm. So remember, for the lateral plate mesoderm, it will have the splanchnic, and then it will also have the parietals. So splanchnic now will come and form the muscular component of the various tracts. Then the parietal will go and form now the bones of the appendages. Then for the endoderm, of course, now it will form the lining epithelium of respiratory system, and also the lining epithelium for the gastrointestinal system. So that is it. And these are brief summary of what we are going to see there. So the ectoderm gives you the epidermis, the central nervous system, and the rest of the neurocrest derivatives. We'll cover this well when we go to the development of the head and neck. Then mesoderm, we've seen the structures that it gives, ideally even the intermediate mesoderm, giving you the urogenital system, you can see it there. Then the endoderm, the digestive system, the lining epithelium of digestive system, and the respiratory system, Of course, the pancreas, the liver, all those structures, the glandular uh, structures in the GIT will be coming from endoderm, given they'll be coming from the lining epithelium. Yeah, so for the axial skeleton that you're going to talk about today, remember it will be coming from, so for parietal mesoderm, it will give rise to the neurocranium and the spine. So remember the neurocranium deals like the skull and then the spine also. Then for the lateral plate mesoderm, it will give us the limbs, the skeleton of the limbs, and then the neurocrest cells will give us the viscerocranium. So the viscerocranium are the bones of the face, for example, on the maxilla, the mandible. Yeah, those bones, and even the hyoid bone, all of them will be coming from the neurocrest cells. Yeah, so those are some of the structures that will give rise to the skeleton of the body. So paraxial mesoderm will give us the neurocranium and the spine. So spine, you're talking about the vertebral column. Then the lateral plate mesoderm will give us the limbs. Then lastly, neurocrest cells will give us viscerocranium. So talk about the bones of the face. Yeah. And we'll see how these bones of the face will develop when we now cover development of head and neck structures. So these are brief summary. Sorry, remember, this paraxial mesoderm is just next to the neurotube. So what will happen is that this paraxial mesoderm will undergo development of somites, which you call it somitogenesis, but this is just a brief overview, a longitudinal cross-section of what you're supposed to see at day 22. We can see we have the neurofolds. So remember the time of the fusion of the caudal neuropore and the cranial neuropore, the timing. And then also you're supposed to appreciate development of the soma. So if you have a cross-section on day 22, what will you be able to observe? You'll be able to observe a notochord, and then you see the neurotube being there, and then the neurocrest. Of course, the surface ectoderm at this point has already been formed. And then, of course, now we've continued maybe at around day 28, day 30, you'll appreciate that the paraxial mesoderm, the intermediate mesoderm, and the lateral plate mesoderm will already have been formed. And then you have now the development of the structure. So at this point, the paraxial mesoderm will be now making the somites, as we'll see in a few minutes. So we start us off with the skull. So remember, the skull, we'll divide it into two. We'll start us with the cranial vault, or we'll start with the neurocranium, then you go to the viscerocranium. So for the neurocranium is the one that covers the brain. Viscerocranium is the one that ideally forms the face. So neurocranium has two parts. It has membranous parts, and then it has a cartilaginous part. So when you talk about membranous part, you're talking about that part of the neurocranium is formed by membranous intramembranous ossification. We talk about this part of neurocranium has cartilaginous part. You're talking about that part is developed from endochondral ossification. So for membranous parts, ideally, those are the flat bones of the skull. So talk about both parietal bone, talk about frontal bone, talk about temporal bones, the occipital bones. They will be formed by membranous ossification, intramembranous ossification. But of course, some of them will be different in terms of some of them will be formed by both intramembranous and endochondral ossification. For cartilaginous parts, which is now the chondrocranium, so all the bones of the chondrocranium, that is all the bones of the base of the skull, will be formed by endochondral ossification. That's the reason why it's very important for us to relate that. Then, now for the viscerocranium, this viscerocranium is somewhat simple because it will be coming from neurocrest cells. So remember, these cells will come together and then they will form some things that are known as pharyngeal arches. These pharyngeal arches will develop around the pharynx. That's the reason why they're called pharyngeal, because they're just next to the pharynx. So they develop around the pharynx, and then they're coming from neurocrest cells. And now these pharyngeal arches will form muscles, will form bones, will form even the derivatives of head and neck structure. So talk about the mouth, talk about the nose. All of them will be coming from the pharyngeal arches. So that's the reason why the bones of head and neck, especially the maxilla, the mandible, the hyoid bone, all of them will be coming from pharyngeal arches. And now they will be coming under, we won't call it endochondral ossification, but it's both endochondral and intermembranous ossification. But most of them are formed by endochondral ossification. So let's start with the membranous parts of the neurocranium. So you'll find that the cells, these points, the origin of these cells, the mesenchyme that forms the membranous neurocranium, will be coming from neurocrine cells and paraxial mesoderm. So the origin of the cells that form the membranous neurocranium. So the bones, so the parietal bones, the frontal bone, the temporal bone will be coming from neurocrine cells and paraxial mesoderm. But most of the time it's neurocrine cells. So the mesenchyme surrounding the brain invests it. So the mesenchyme that is not surrounding the brain will invest it, like we surround it well, and then it will undergo membranous ossification. So with the result of this is that you'll find a presence of a flat, membranous, and needle-like bone spicules. And these needle-like bone spicules will now move towards the periphery. As we'll see in the next slide, in an image, we'll appreciate that these flat membranous needle-like spicules will become the primary ossification centers. And then these primary ossification centers will try to radiate, will try to move towards the periphery. They will extend toward the periphery. And the key word at this point is to radiate from the primary ossification centers to the periphery. So this membranous ossification will be coming due to osteoblast. So the mesenchyme, remember I told you, mesenchyme is undifferentiated mesoderm. So when now it differentiates and becomes bone lineage, you'll get osteoblast. Osteoblast, now they will deposit, it will deposit matrix, osteoid. And through that, now you'll get ossification happening. When you continue to deposit osteoid, you'll ideally be making bone. And with now continued radiation from the primary ossification center to the periphery, you first of all form various bones, and then in addition to that, you'll be forming sutures and various fontanelles in between various bones. And that's the reason why this slide is here, just to show us that this parietal bone, these frontal bones, like they had different primary ossification centers. And then in between, we had sutures and fontanelles being developed. Yeah. So at this point, actually, you can appreciate how the anterior fontanelle is formed. It's formed by presence of two parietal bones and two frontal bones before the frontal bone fuses. And even you can get to know the various sutures that you have. So of course, you have the coronal suture, we have the lambdoid suture, we have the sagittal suture, all those sutures that we know. Yeah, and even the 6 fontanelles, the sphenoidal fontanelle, which are 2, the mastoid fontanelle, which are 2, and then the anterior fontanelle and posterior fontanelle, 2. So ideally, we have like about 6 fontanelles. Maybe I can pose a question to you, to us. Maybe someone can put it in the chat box. How many, what are the functions of fontanelles? What are the functions of fontanelles? So if you know, maybe you can put your answers in the chat box as we go ahead. Then we can go to the next bit, which is now the cartilaginous bits of the skull. So the cartilaginous bits makes the chondrocranium. So, and this chondrocranium is the base of the skull. So you'll find that the base of the skull will be formed by irregular bones. And those irregular bones, they will be formed by endochondral ossification because you have a cartilage that is just anterior and posterior of the notochord. So the point to note in this is that as you're going to start in this, you're going to start with the basis of that. You already have a pre-existing cartilage in front and posterior of notochord. Yeah, so of course at this point they're coming from neurocrest cells. So neurocrest cells is the one that gives rise to these cartilages. Then of course with time you'll find that you'll have cartilages in front and cartilages posterior. So the cartilages that are in front of the notochord will form the bones that are around now the sella tussica. So remember the sella tussica is in the ethmoid bone, sphenoid bone, some part of the frontal bone. So those bones will be formed from neurocrest cells and the cartilage that is just anterior to it. Then remember, we said, how does endochondral ossification happen? Endochondral ossification happens when you have, first of all, presence of a cartilage. Then the cartilage forms cartilaginous models. These cartilaginous models become the chondrocytes. They become invested by osteoblasts, and then osteoblasts lays matrix within the cartilage, and now through that you get to develop the bone. So that's how ideally you get the cartilaginous chondrocranium that is just anterior. So the sphenoid and the ethmoid bones, some part of the orbital part of the frontal bone will be coming from neurocrest cells, giving rise to the cartilages that is just rostral to the notochord around the sella tussica. So you know the various components of sella tussica, the dorsum celli, those parts of sella tussica, the four of them. So be conversant with them. Then you also have the precaudal chondrocranium. So this precaudal chondrocranium will be formed from, like you're calling it precaudal, like it's just anterior to the notochord. So precaudal chondrocranium will be coming from this cartilage that is just anterior to the notochord. So what about this cartilage that is posterior to the notochord? It will be coming from occipital sclerotum. So occipital sclerotum will form now will form the cartilages that are just posterior to the notochord. And now through that, we'll have the cartilages forming hyaline cartilaginous models. Then this hyaline cartilaginous model undergoes endochondral ossification to form bones that are just posterior to the notochord. So talk about the occipital bone, talk about some portion of the temporal bone, the styloid process, the mastoid process, all of them will be coming from the occipital sclerotum. Then for the viscerocranium, now the viscerocranium, and this is a point that I want us to maybe pay a little bit of attention. They will cover it again when you do development of head and neck. And that's the reason why in this slide it's written development of the face. Because all these processes, so the frontal nasal process, medial nasal, all those structures will cover them well when we're talking about the development of the face. But you see this one, the one that is labeled number 4. You can see here it's the maxillary process. So the maxillary process and the one that is in purple, if I'm not wrong, that is the mandibular process. So those two are the one that will give us the maxilla and the mandible respectively. So they'll be coming from neurocrest cells. Actually, you'll appreciate that they are two. So you have two mandible and then you have two maxilla. Then they will fuse at the center. So telling you if something goes wrong, you'll have cleft lip, cleft jaw, cleft palate. So at this point, just know that the bones of the viscerocranium will be coming from neurocrest cells, coming from the various pharyngeal arches. And then remember the pharyngeal arches are coming from the neurocrest cells. So neurocrest cells, they aggregate, they form the mesenchyme. The mesenchyme then forms head and neck structures. This mesenchyme will form pharyngeal arches. The pharyngeal arches will give the various structures of head and neck. I hope that tries to summarize things. So at this point, you even can appreciate that even the head and neck, the nose, the eyes, some portion of the eyes, the nostrils, like they're coming from these pharyngeal arches. They're usually 6 in number, but we'll see how they develop when you go to head and neck. So this is just a summary of how the various bones of the chondrocranium come across. You'll appreciate that. Now, the ones that are in blue will be formed from the precaudal chondrocranium, like precaudal chondrocranium. Then the one in, I guess this one is some more orange. they'll be coming from. Now, posterior to the notochord, the occipital sclerotom. Occipital sclerotom is the one that will give rise to this bone. So talk about the petrous part of uh, temporal bone, talk about now the base of the occipital bone, talk about the base of occipital bone, the body of sphenoid will be coming from now the occipital sclerotom. Then now the remaining, so talk about the ethmoid, the lesser wing of sphenoid, the greater wing of sphenoid, and even the celatosica will be coming from the precaudal contractile. So that's image tries to summarize everything. Then for this image, maybe if you can go ahead and look at it, at this point, I would like us to talk about it. It's a little bit complicated at this point, but maybe you can go ahead. I remember in a time you were asked, okay, now BSc exam, you were asked about what are the derivatives of the orbitosphenoid. So orbitosphenoid, of course, if you know it's the lesser wing of sphenoid that comes from it, you can be good to go. Then talk about the supraoccipital. What does the supraoccipital give rise to? Gives rise to the occipital bone. So you can go through it, but it's also not a must for you to go through it. So some of the anomalies of the head and neck structures and of the skull at this point, you have craniocytosis. So craniocytosis, ideally, a spectrum of anomalies that come across due to abnormal fusion of sutures and fontanelles. So remember, if you have like now all the sutures fusing prematurely, it can give you a small head, which is microcephaly. But now if you have maybe one of the sutures like closing earlier, and then the others, they close normally, you won't have microcephaly, but you'll have maybe another anomaly, which you'll see in a few minutes. So craniocytosis can come from microcephaly. Craniocytosis can give rise to microcephaly, but microcephaly can also come from other causes such as infections, malnutrition, such things. So some of the viruses that cause that cause microcephaly are actually Zika viruses, usually have rubella. Yeah, they usually cause microcephaly. Then for anencephaly, ideally, failure of development of the brain will lead to failure of development of the skull. So in embryology, you'll find that it's one structure induces formation of another structure, and then that other structure induces development of this other structure. At this point, you have the brain and the skull. So presence of the brain will lead to formation of the skull at this point. So absence of now the brain, that is an encephaly, will lead to like a calvaria, absence of the cranial folds. And then macrocephaly, of course, at this point is maybe large skull, pronounced skull at this point. Yeah. So remember, macrocephaly can come across due to hydrocephaly. Hydrocephaly, you have now issues to do with circulation of CSF, the cerebrospinal fluid. And the first of the anomalies that we'll cover, okay, you can appreciate this is normocephaly. So normocephaly is there. We can also have now, if you have earlier fusion of metopic suture, you have trigonocephaly. And then if you have normal suture, you can also have scaphocephaly, you can appreciate scaphocephaly. So this suture here closed earlier. Then you can also have unilateral closure, earlier closure. So this one fused earlier. And that's the reason we have posterior plagiocephaly. And also at this point, you can appreciate that. Then this one is anterior, like this one closed earlier. Then it's brachycephaly. But this thing to do with anterior and posterior plagiocephaly, you're not supposed to know about them. But just know this is plagiocephaly, this is brachycephaly, this is scaphocephaly, this is trigonocephaly. So trigonocephaly, you can appreciate you have an issue to do with your coronal suture at this point. This brachycephaly. So this person with brachycephaly will have a towering head. Person with scaphocephaly will have a pointed head. Okay, like a boat-like head. And then for person with trigonocephaly, will have like a head that is projected anteriorly. So projected anteriorly, trigonocephaly. And then, of course, you know, this is anencephaly leading to a calvaria. So a person with anencephaly doesn't have a skull, a cranial bones. Yeah, so this one is, at this point, But I want you to make sure that if you brought such an image in your exam setting, just write it as an encephaly and not a calvaria. Yes. Then of course, at this point, you can appreciate presence of macrocephaly. Macrocephaly is coming across due to enlarged ventricles. So these are the various ventricles of the skull. So this is the lateral ventricles, actually two. So if you have now obstruction of circulation of cerebrospinal fluid, you'll have macrocephaly. Macrocephaly also can come across due to overdevelopment of the bones of the skull. Not only also in increased intracranial pressure, you can also have overdevelopment of the bones of the skull. Then now this one is a typical hydrocephaly. So at this point, you can appreciate some of the typical uh, signs of hydrocephaly is sunset eyes. You can also appreciate bossing of the skull. You can appreciate small viscerocranium. Those are some of the signs of hydrocephaly. So a time will come when we'll now be talking about differentiating between the two types of hydrocephaly, communicating and non-communicating. For communicating, you have an issue to do with the secretion of CSF. For non-communicating, you have complete obstruction of circulation of CSF. Then, no, this one I presume it's kind of obvious for us. It's just direct microcephaly, then the rest. This one is just like normal cephaly. This is microcephaly. So you can appreciate presence of trigonocephaly here. So this trigonocephaly, projected head, scaphocephaly, we talked about it. Yeah, those are the various anomalies that we're talking about. So normal presentations are there. We can appreciate this one is normal. This plagiocephaly. So ideally, the lambda is which are fused on one or posteriorly, but on one end. For brachycephaly, like it was uniform. And then on scaphocephaly, it's the sagittal which are that fused. Yeah, earlier. Then you can appreciate now similar thing happening there, brachycephaly, plagiocephaly, and scaphocephaly happening respectively. Yeah, I guess you can go to the vertebral column, but before you go to the vertebral column, does anyone has any question? Yeah, I can see like you put the answers very well. So I can see Eric say that allow an enlargement of the cranial wall to accommodate the growing brain. Very correct. Same case to Katrina, you say the ideal to enable overlapping of the skull bone during birth. Correct. Same case to Sandre. Okay, this Sandre, I hope it's Sunny Ray. Then for William Tebelo, it's also saying give rise to the growth of the brain. Exactly. And then in addition to that, they also try to give rise to enable the like measurement of the intracranial pressure sometimes. And even they allow remodeling of the brain, of the skull during birth. They just enable development of the skull. So for hydrocephaly, so hydro means water, and then cephaly is a brain. So it's like increased amount of uh, brain, amount of CSF, cerebrospinal fluid. Remember, CSF like comes from secretions that come from ideally the circulating venous blood. So of which now it doesn't have the blood cells, then it won't have some components of the plasma, so it will contain majorly water. That's the reason it's called hydro. So increased amount of water in the skull, in the brain region. So it can either be due to, remember there are two, we talked about communicating and non-communicating. So the reason it's called communicating is that we don't have communication. Okay, communication is still there. That's the reason it's called communicating. You have an issue now with the production of CSF. So you have now the choroid plexuses are producing this CSF. They have mutated. So that is they're producing more. But not for non-communicating, it means that there is an obstruction. You have normal production of CSF, but now for that CSF, that cerebrospinal fluid to circulate, it can't circulate well because you have obstruction. That's the reason why it's called non-communicating or obstructing. So non-communicating is also known as obstructive. And then communicating is also known as non-obstructive. So it's just interchange the words anyway, as long as you've understood the word, what they mean. I hope you've got it. That is, I hope, Eric, you got it well. Then for the vertebral column, we realize that it will be coming from the sclerotum. And a point that I would like us to maybe appreciate is how you get the sclerotum. So remember, the sclerotum comes from the paraxial mesoderm. So during the 4th week, the sclerotum surrounding the neural tube. So this is a neural tube. So ideally, you have the paraxial mesoderm. Paraxial mesoderm undergoes the process of somitogenesis. Somitogenesis means formation of somites. So remember, the somites will be coming from the occipital region going to the sacral region. So from up downwards. So the somites now will form 2 points. They'll form the derma myotome and the sclerotum. So at this point, these are derma myotome. So the dermatome and then the myotome. So dermatome will give us the dermis, the back, and then the myotome will give us the muscles. Then the sclerotum is the one that now will give us the skeleton, the vertebral column. So now you remember you have sclerotum on this side, and then you also have sclerotum on this other side. So the cells will surround this developing neural tube, which at this point will give us a spinal cord, and then they will fuse. So after fusing, what will happen next? So let's go to the next slide that you can appreciate what will happen next. So we have sclerotum here, they fuse, they give us like a kinda surrounding on this neural tube. Then remember this, at this point, you want to form the vertebral body. So what will happen next is the process of resegmentation. So at this point, you can appreciate the neural tube is supposed to be here. So the spinal cord is supposed to be here. So remember, this neural tube is the one that will give us the spinal cord. The spinal cord will be formed here. So that means now all these will be coming from the sclerotum. So how do they come across? They come across by, just a minute. So they'll come across due to, okay, we talked about the paraxial mesoderm undergoes somitogenesis to form the somites. Then the somites will divide into derma myotome and the sclerotum. The derma myotome will divide into two, the dermatome and the myotome. The dermatome gives you the dermis of the back. The myotome gives you the muscles. Then the sclerotum will give you now this, like ideally the vertebral column, and also the ribs. So the sclerotum cells that are now fusing around this, the neural tube will fuse with sclerotum from the opposite side. And after that, now we'll have the process of endochondral ossification happening. But before then, we'll have resegmentation. So resegmentation means you have these somites. So the somites will divide into two. You have the cranial part and the caudal part. So the resegmentation now will happen that in such a way that cranial part will fuse with the caudal part of adjacent somites, as we'll see in the next slide. So some resegmentation happens to form the vertebra. And now for this vertebra to be different, because you know the cervical vertebra is not similar to us, the thoracic vertebra. So the patterning, the differences will be coming due to patterning by the Hox genes. So these are just more, the Hox genes that are found in the body. So these Hox genes will lead to presence of various molecules. Those molecules will lead to like concentration of various molecules. Those various molecules will lead to like formation of different types of vertebrae. Then the mesenchyme between the sclerotum forms, the mesenchyme between the various sclerotum will form the IVD, especially in which part, the annulus fibrosus, and then the notochord will degenerate, but except the nucleus pulposus. And then we also remember the notochord will also give us some ligaments. The ala ligaments, the pectinate ligaments, all of them will be coming from the nucleus pulposus. So a point to appreciate is that, and this will be explained using this slide here. So we have the notochord there. Is a notochord. So we have now the sclerotum that are just next to this notochord and the neurotube. So they will undergo resegmentation. Resegmentation means, and actually, let me just address this right now. The meeting is going to end because I'm not using a paid Zoom account, but we can, when the Zoom meeting ends, kindly rejoin. We go for the next like 20, 30 minutes, then we'll be done. So I also like cover this development of the vertebral column well. So if you be logged out, another link will be sent, so kindly rejoin. Yeah, so as I was talking, okay, let's just allow the 1 minute to end then, because it's just 1 minute remaining. So rejoining the next, just come and then we'll go ahead. So we were talking about the process of resegmentation. Let me just take you back to this. So remember, at this point, you have the paraxial mesoderm being one of the components of the mesoderm. So remember, for the mesoderm, you have the paraxial mesoderm, intermediate mesoderm, and lateral plate mesoderm. So for this paraxial mesoderm, it will undergo the process of formation of somites, which is known as somitogenesis. Then the somites will divide into two, the dermatomitum and the sclerotum. We say the dermatomitum will divide into two parts, give you the dermis, the dermatom, and the myotom. So the dermatom will give us the dermis, then the myotom will give us the muscles. Then for the sclerotum, it will give us now the ribs and the vertebra, and also some portion of the chondrocranium, that is the occipital sclerotum. So the sclerotum that is now surrounding this neurotube will fuse with the sclerotum from the opposite side, giving us a definitive mesenchymal cell surrounding the neurotube. Then the process of resegmentation happens, and I was explaining the point to do with that. So in segmentation, remember, just imagine we have, these are the somites. Okay, this is a notochord, and the neurotube is there. So you have this as a somite. So this is a somite, this is a somite. So what will happen to this somite is that it will divide into two. So this somite will divide into a cranial portion and a caudal portion. Same case, now you can appreciate this is a caudal portion, and then this is a cranial portion, then this is the caudal portion. So the caudal portion will fuse with the cranial portion of adjacent somites. Same case to this. So at this point, you have now a caudal portion and a cranial portion of the overlying somite fusing. So it's like the somite divide into two. You have a cranial portion of the somite, and then you have a caudal portion of the somite. So those two will divide. And then now the cranial portion, for the one that is just above, will fuse with the caudal portion of the somite that is now above that cranial portion. So by that portion, we'll have now the vertebral column coming from the caudal and the cranial portion of each. And actually, the exemption of this is now the atlas. The atlas of the vertebral column. The reason why it doesn't have like a caudal portion coming from the above sclerotum, given the fact that there is no somite above the first somite. So by that virtue, it just have to be formed by just the caudal part of the cranial portion of the somite. So you'll find that now, in between, that's the reason you can appreciate that now the notochord is there. Then the notochord will degenerate. When it degenerates now, it will give us, it will continue to degenerate, except in between the two developing vertebrae. Because at that point, you're forming the vertebra. Like you've already formed the somites. The somites have already undergone the process of division. They've given you the cranial and the caudal portion. The cranial and the caudal portion have fused to give you definitive vertebra. So in between all the vertebrae, you'll have mesenchyme that is in between that will differentiate and proliferate to give us, first of all, the annulus fibrosus. And then the notochord that is in between will degenerate, except now on this intersegmental mesenchyme, where it will persist as nucleus pulposus. So at this point, we can confidently say that the intervertebral disc, which is in between the two vertebrae, will be coming from the nucleus pulposus and the annulus fibrosus. So if you forget everything that I've just said, just remember that vertebrae are coming from cranial and caudal portions of various somites. And then intervertebral discs are coming from intermesenchyme that is in between these forming vertebrae and then the nucleus pulposus. So nucleus pulposus coming from the notochord, and then annulus fibrosus coming from this intersegmental mesenchyme that will proliferate, and then it will undergo the process of deposition of fibrinogen to give you now the fibrous, and then the deposition of collagen and other structures, making it not to harden to give you now a definitive fibrous cartilage that will be found in the intervertebral discs. So now you'll have a few anomalies of the vertebral disc and also anomalies of the vertebra. So the first anomaly for us to cover is known as spondylocostal dystosis. So by just the name costal, like means the thoracic vertebrae. So incomplete fusion of the left and right sclerotum pairs of the centrum in the thoracic region. So the right and the left sclerotum, remember they're supposed to fuse. If it doesn't fuse, they'll give you this spondylocostal dystosis, and you'll see the images in a few minutes. Then you have other segmentation anomalies such as presence of hemivertebra. So for you to have a hemivertebra, it means there was absence of fusion of the cranial and maybe caudal portion of these somites. And then you can also have sagittally cleft vertebrae. You can also have fused vertebrae, maybe the intermesenchyme, the intersegmental mesenchyme continue to form, to ossify and give us a fused vertebrae. And these fused vertebrae, we'll see some of them in the cervical region, which will give us a few brevicolis, which you'll see in a few minutes. Then but most of them, they're actually very common in the lumbar vertebrae, where we find that the fourth and the fifth lumbar vertebrae are fused. It's very common. And also you can also find this fused vertebrae, they can even go ahead and fuse with the pelvic bone. Then, of course, now scoliosis will be coming across due to hemivertebrae. I presume those who went to the lab sessions today, you talked about this scoliosis being by the presence of hemivertebra, being like those are the anomalies of the curvatures of the vertebral column. Then for brevicolis, now a short neck, low hairline, limited neck motion due to fusion of the cervical vertebrae. So this brevicolis presents with a short neck, and now other malformations will have that person will have a low hairline, limited neck motions due to fusion of the cervical vertebrae. Like it comes across, it doesn't come across like only that person will have now and other underlying anomalies that will be known as Klippel-Feil syndrome. So this is now the spondylocostal dystosis. You can appreciate that now even the position of the ribs and the neck itself is not on its normal position due to the abnormal fusion or absence of fusion of the right and the left sclerotum in the thoracic region. So these are characteristic of spondylocostal dystosis. This one is now scoliosis. This one is scoliosis. Of course, you know, scoliosis presence of a hemivertebra. Then this one is now the brevicolis one. So this one is brevicolis. Can appreciate short neck. Yeah, a presentation of brevicolis. You're almost done. You're almost done, so don't give up. You're almost done. Maybe anyone with a question regarding this and development of the vertebral column. So for vertebral column, they'll be developing from somites. The somites will divide into these cranial and caudal portions. They'll fuse. Then after fusing now, remember those are cartilages. They'll develop by endochondral ossification. Then for the various processes to come, you need to have now primary ossification centers and secondary ossification centers coming across. Yeah, so given that there's no question, can you allow me to go to the next structure that I want us to form, which is the clavicle. So for the clavicle, it's the first bone to start ossifying and the last bone to complete its growth. So it develops by both intramembranous and endochondral ossification. So for intramembranous, it's now the shaft. But now for the ends, it will be by endochondral ossification. So you'll have like now a membrane being invested by osteoblast, giving you intermembranous ossification. That is a shaft. Then for the ends, that's the reason why they're irregular in shape. You'll find that they have endochondral ossification by the fact that we had cartilages. Those cartilages formed hyaline cartilaginous model, which had chondrocytes. They had now osteoblast coming in, depositing osteoid in the cartilage, giving you those bones that are formed there. Then for the other point that you need to appreciate about this is that we talk about being among the last bones to ossify. So around the age 18 to 20 years, the secondary ossification centers will now appear at the sternal, that is the medial end, and the clavicle completes ossification by mid-20s. So at the age of 25, 26, that's when now this clavicle is fused. And now you find that the clavicle can be used now for forensics. Like maybe a person is lying his or her age, and now they can study the ossification centers in the clavicle to check if the person is maybe lying on his or her biological age. Yes, so anomalies, remember we see that the clavicle develops by endochondral and intramembranous ossification. And then remember the bones of the skull, especially the neurocranium, the flat bones are coming from intramembranous ossification. So you'll find that if a person has anomaly of the clavicle, that person also will have anomalies of the skull. So maybe the person will have patent and anterior fontanelle still, anterior fontanelles, posterior fontanelle till adults. The person will have absence of the clavicle, that is the collarbone. So in this person, you can appreciate there is absence of the clavicle here. Like that's the reason why the person can move the arms that way. Similar case, these are next to you can appreciate there is absence of the clavicle there. So that is cleidocranial malformations. So the person has an issue to do with that. Yeah, so that's majorly about it. And actually, for the movie lovers, those people who love movie lovers, it is a certain character who had this cleidocranial malformation in the academy. So for those people who love watching movies, such cases there. Yeah. And so similar case, you can appreciate this cleidocranial malformation being there. Yeah, so we'll go to maybe the last structure. Okay, we have the sternum and then we'll go to the ribs. So the sternums will come from the lateral place mesoderm. How? Remember during lateral folding, in lateral folding, you have now formation of cartilaginous models. So a pair of cartilaginous models that converge in the ventral midline during lateral folding. So, and this one you'll appreciate it well using an image. Then you have the lateral mesoderm giving you these cartilaginous bands. The cartilaginous bands will undergo segmentation in cranial segments, and then you have endochondral ossification happening, and then you have fusion of the segments and ossification. Maybe a point to appreciate is that you'll have some anomalies coming across. First of all, if you don't have these cartilaginous bands coming from either side fusing, or you can also have incomplete fusion, or you can have complete absence of these cartilaginous bands. So failure of fusion of these cartilaginous bands will lead to like a split xiphoid process or maybe a split sternum. Sternum formation is guided by anterior border of the Hox code. So remember the Hox genes are the ones that regard the level of formation of the sternum, the level of formation of various vertebrae. So the Hox genes are just patterning and alignment of bonds. So we can start with this. Remember this is happening during the process of lateral folding. So at this point, I presume you've talked about the cranial caudal folding and then the lateral folding. So the lateral folding, now you have the lateral plate mesoderm on either side. And which part specifically? Now the parietal. So the parietal part of lateral plate mesoderm will come toward each other. First of all, to give you these cartilaginous bands, which are known as the sternal bands. So you can appreciate there are two. So due to the lateral folding, they'll fuse. So an anomaly can come across in this. Failure of fusion will give you a split sternum, a split xiphoid process. Okay, then another thing will happen is that we'll undergo segmentation. So segmentation will happen now to form the various components. And this segmentation will give you the various ossification centers. So you'll have about 2 ossification centers for the manubrium, about 3 ossification centers for the body, and then 1 for the xiphoid process. So that's how it comes across. And that's the reason I appreciate that the sternum has various segments, especially the manubrium and the body. So remember, we've talked about various anomalies here. So complete absence or maybe absence of formation of some part of the sternum will give you another anomaly that we'll see in a few minutes. Absence of fusion or incomplete fusion will give you another anomaly. And then also you can have overdevelopment of these sternal bands or underdevelopment of these sternal bands. So for cleft sternum, absence of fusion of the 2 sternal bands. Ectopia codis, absence of formation of these sternal bands. Maybe it might be proximal, it might be distal, or maybe in the middle, giving you ectopia codis. So ectopia means the one that is, so like it's found in an abnormal position. Codis means heart. So due to absence of the sternum, the chest bone, will make the heart to be found in its abnormal location. That is the reason it's known as ectopia codis. Then for pes carinatum, so carina is related to pigeon. So like the person has pigeon chest. Pigeon chest. So the chest that is projected anteriorly, like more anteriorly. For excavatum, a cave. So the thorax look like a cave. And that one you can appreciate it here. So this is a normal chest. This pectus excavatum, a cave, like the chest has a cave, excavatum. Then for pectus carinatum, the person has like a pigeon chest. Like pigeon chest, like you know the chest of a pigeon, or maybe a bird is projected anteriorly. That's the reason why it's known as pectus carinatum. And this is well represented in this. So you can appreciate this pectus carinatum. It's known as pectus excavatum. So the reason is now anomalies in development of the sternum. So maybe this one will have like overgrowth of the sternum, undergrowth of the sternum, or maybe an issue to do with the ribs, making it to be that way. Yeah, but this is pectus carinatum, pectus excavatum. For the other one, this one you can appreciate, like the sternum is there, but no, they are not fused well. So I don't want you to appreciate that this one is another one. We'll talk about this later, but now at this point, I want us to focus on this. So this one is the cleft sternum thing. Then same case, cleft sternum. And now for this one is now ectopia codis. We'll also cover this anomaly in the development of the cardiovascular system. In the ectopia codis, we appreciate that some portion of the sternum will be missing. Maybe we can finish up with the ribs. So the ribs will be coming from the sclerotum that remains in the paraxial mesoderm. So remember, the sclerotum was forming the vertebral column, but we have some portion of this sclerotum that will remain, that will give rise to the ribs. And now that is now on the region that is just next to the vertebral column. What about the region that is coming from the sternum? So before then, these sclerotum cells, they will grow out to form the costal processes of the thoracic vertebrae. But remember, that is now the costal process of the thoracic vertebrae. What about now the region that is coming from the sternum? The costal cartilages are formed from sclerotum that migrates across the lateral somitic frontier into the adjacent lateral plate mesoderm. So we usually have somitic frontiers. We usually have ventral, lateral, and caudal somitic frontiers. So this one has to do with migration of neurocrest cells and how well you are able to understand that. So I want to take you back to migration of neurocrest cells and the folding processes, but just get that the sclerotum that will remain on the paraxial mesoderm will form the ribs. Then these sclerotum cells will grow, they will proliferate from the costal process of the thoracic vertebrae. And then the costal cartilages. So remember, a rib is attached to the sternum by costal cartilages. So these costal cartilages are formed from sclerotum cells that migrate across the lateral somitic frontier into the adjacent lateral plate mesoderm. Yeah, so anomalies for the ribs, remember, we have 12 pairs of ribs, that is 24 in both males and females. We can have excess. We can have cervical ribs. So cervical stroke accessory ribs. So for cervical ribs, there are accessory ribs that are found in the neck region. So you can just tell that person will have more than 24 ribs. So given that the person has accessory rib, so more than 24 ribs. So of course it will have some pathologies given the fact that it will compress the brachial plexus, it will compress the subclavian artery, the subclavian vein, and even sometimes the brachiocephalic trunk. So those are some of the pathologies that may present. So the person may be feeling like pain in moving the arm or something like that. Another anomaly that I didn't put here is known as the gorilla ribs. So gorilla ribs are known as gorilla because in gorillas, they have 6 vertebrae, six lumbar vertebrae, unlike in humans where you have 4. Where you have 5. So in that one now, that means now there'll be a rib coming directly from the lumbar vertebrae. So when you have cervical ribs, they're coming from the cervical region. Gorilla ribs, they're coming from the lumbar vertebrae, specifically now from most likely L1 vertebrae. Yeah. So some of them, so for the gorilla ribs, they actually are found in like 1 in 1,000. And then they are not somehow, they are asymptomatic. As long as they're not compressing anything, they're just asymptomatic. It's not like the cervical ribs, which will compress the brachial plexus. And at this point now, we can appreciate presence of cervical ribs in this. Yeah, then we can appreciate in this cervical ribs compressing the subclavian artery. Some of them will compress the brachial plexus. Yeah. So remember, we usually have a triangle here that is known as scalene triangle. And the scalene triangle will carry the roots of the brachial plexus and even subclavian artery. But subclavian vein won't be there. Yeah, I guess that's it for. I didn't have an image on the gorilla rib, but you can go ahead and check about gorilla vertebrae, gorilla ribs, and such things. Yeah, so maybe to encourage us is that we should always be in the presence of the Most High, in the presence of the Almighty Lord, because He's our refuge, He's our fortress, He's our strength in each and every way. So we should continue trusting in Him. Doesn't matter the circumstances that we found ourselves in. Like God definitely see us through. And I have nothing much than good luck as you prepare for your Cat 1 exam. And may you have that concentration, may you have that wisdom that you require as you narrow down towards your exam. So with that, I have nothing much but thank you. I don't know if anyone has a question, but yes, that is what I have for us at this point. Maybe I can take some few questions and then we'll go ahead. But meanwhile, these recordings will be posted in my YouTube channel. So if you require them, maybe you can go ahead and you'll see them in the YouTube channel. But a point to appreciate is that just make sure you like, share, and subscribe in short. Yeah, but